Right, we're very lucky tonight. We've got Professor Michael Cooper speaking to us. He's a gynaecologist and a clinical associate professor at the University of Sydney. He's also a visiting medical officer at Royal Prince Alfred Hospital and St Vincent's Private Hospital, as well as having rooms in the city. He graduated from Sydney University and received his ONG fellowship qualification in 1995. He spent extensive time training in endoscopic surgery in Europe, United Kingdom, and America. Initiated early endoscopic training centres for gynaecologists in Australia and is regularly involved in workshops training other doctors. He's been a board member of the Australian Gynaecological Endoscopy Society and he's served as a member of the scientific committee of the International Society for Gynaecological Endoscopy. And he's even served as an advisor to the World Health Organization on research and training in gynaecological endoscopic surgery. In 2018, he was awarded an Order of Australia Medal for services to gynaecology. And Professor Cooper has been the author of over 50 peer-reviewed journal publications and book chapters. He's been an invited speaker and invited endoscopic surgery trainer at multiple hospitals, both here in Australia as well as overseas. And his major interest is in the treatment of endometriosis, including complex cases requiring advanced laparoscopic surgical or even robotic techniques, as well as an interest in assisted conception techniques. He's performed over 2,000 operative laparoscopies just for the treatment of endometriosis. So with that wealth of experience, we are very grateful that he's agreed to come along and talk to us tonight. And he's going to be talking about endometriosis and including some information about dysmenorrhea, adenomyosis, and pelvic pain. So it's a very useful topic. So big welcome, Professor Cooper.
Thanks very much, Janine, and Lydia and yourself for the invitation. And look, it's really, I'm surprised and encouraged to see there's so many people online to take an interest in this topic, you know, on a sort of an evening and to spend so much of your time. So I sort of welcome the interest, and I'm hoping that I can, I guess, get through some of the sort of issues that we also struggle with in relation to this terribly difficult and particularly poorly understood sort of topic. I'm assuming you can all see that screen in front of you. I'll take that as a yes.
Yep.
So I don't really have any conflicts that would conflict with what we're talking about tonight. In broad terms, what I'd like to do is talk broadly about endometriosis. My key sort of takeaway really relates to the definition and the way we manage this, because I think expectation management is a huge sort of problem for both, you know, patients and doctors. And unless you get that right, it really creates difficulties in terms of how we manage things. And I think that sort of flows through as to show why there's so many people on the line, you know, on this meeting tonight. I'll run through some surgical issues, not so much in specifics, but to be able to just give you, I guess, a feel of the sort of things that run through our minds and what happens and what this disease is capable of doing. And then I'll touch on some issues in relation to pain, inflammation, and finish off with some fertility issues. And then focus a little bit on what I would call my sort of four pillars of how I would manage things. But broadly speaking, you really want to individualize sort of management. As you all know, it's an exceedingly common condition, and a number of these people sort of illustrated below are said to have had endometriosis. Whether that's true or not, I don't know, but it's been spoken about fairly widely. So the issue is, look, you know, amongst other things, this can be a terribly, terribly debilitating condition with, you know, obstructed ureters, involvement of the appendix, bowel, and sort of major issues for patients. So these are just sort of some images illustrating some of the sort of significant issues we see, as I say, with obstructed ureters, endometriosis. You can see, you know, coming through this, you know, the front of the bladder, and on the bottom right, that's a diaphragm where we've gone into the chest and we've removed a bit of diaphragm and had to put a mesh sort of repair over that area. I'd start off by suggesting that our current definition is highly problematic. The issue being that, you know, the current sort of narrative is that endometriosis is the presence of endometrial glands and stroma outside the uterus. The problem with that definition, if you tell that to patients, and if you believe that, you wind yourself up in knots, because the patients then not unreasonably say, well, why don't you just remove that and that's the end of the problem? But it doesn't work like that. And the problem is that there's a whole pile of other things going on that we don't tend to talk about. We can't image, we can't scan, we can't test for, but we know from a research point of view that there's a whole pile of other abnormalities. So expectation management basically becomes a problem. And if you're simplistic in your definition when you're talking to patients, they will sort of expect, well, why can't you just fix me? But as I say, it doesn't sort of work like that. There's a recent sort of Lancet review illustrating this point, outlining the fact that really what we're talking about is a chronic systemic disease affecting a whole range of organs, and that this aspect of endometrial glands and stroma being outside the uterus is only one aspect of that problem. So I think as a starting point, if you don't take anything else out from tonight, I think that's a highly useful thing to be able to say to your patients, because it then sets you up to be able to have a much more meaningful dialogue and a positive sort of way that you manage things. I just put into Chat GPT and asked for their the current thinking on endometriosis, and it's the same thing. So around the world, increasingly people are starting to say that really what we're talking about, we need to expand this definition, and what we're really talking about is a chronic systemic inflammatory problem, and the presence of endometrial glands outside is just one aspect of that problem. The flow-on of that, of course, is to mean that surgery alone is not the answer. So surgeries, yes, it can be a very important component of management, but it's definitely not the only thing. And if you sort of suggest that to patients, you're going to have a problem. So I think that's a very good take-home sort of message. It's difficult in the sense that there's sort of wide-ranging multiple symptoms and can be exceedingly difficult to work out what's happening. So these people, often they'll have pain, but not always. There's a reasonable number of people who will be infertile, so probably up to 50% or more of patients who are trying to get pregnant, failing to do so, who may not have any other symptoms. Something like 50% of those are going to have endometriosis. Pain, bowel, bladder, sexual, abdominal, pelvic is obviously well sort of known. You can get sort of leg pain. It tends to be sort of anterior rather than the posterior, but through the thigh. Bowel issues are exceedingly common. And a large number of people have been told they've got irritable bowel syndrome. Fatigue, headache, and sort of systemic issues also widely common. And there's a huge number of immune inflammatory conditions, so associations with things like thyroid problems. One sort of thing that I find exceedingly useful, and I ask almost everybody, is in relation to premenstrual spotting. So if patients describe a brown sort of spotting before their period, they've probably got a better than 75% chance they're going to have endometriosis. As I'll allude to in a minute, the interface between the endometrium and the myometrium is abnormal in patients with endometriosis, even though it may look normal on ultrasound. And so perhaps that's why they have these sort of menstrual irregularities and this sort of brown sort of spotting that they describe. As I sort of alluded to, there's multiple abnormalities. So here in the sort of on the bottom left is a sort of a normal sort of view of a uterus, cervix, top of the vagina, tube and an ovary. Most common place to get sort of endometriosis in the sort of the true definition form is in the uterosacral region here, which can come across towards what's become known as the torus, which is the space between the uterosacral region and the back of the uterus, top of the vagina. And here we've got histological sort of endometrial glands and stroma on the right. As I alluded to, together with Ian Fraser and a number of people from Sydney University, years ago, we developed a test which we thought was going to be great, where we took the eutopic endometrium of people with endometriosis and demonstrated it was different. So you could find nerve fibers in these sort of people, which other people didn't have. Unfortunately, the assay was difficult to repeat, but it did raise the tantalising prospect that you could diagnose endometriosis by endometrial sort of sampling. But that's just it's become difficult. But it does illustrate the point that, as I say, this endometrial myometrial interface is different in people with endometriosis. We know there's genetic sort of issues, and I won't go into that, but it's quite clear that families will have, linkage patterns. There's a number of different loci that have been identified over the years to tell us that there's issues. We know there's a whole pile of range of immunological aberrations. So if you look at the peritoneal fluid of people with endometriosis, it's distinctly different from other sort of people. Whether that creates ongoing further inflammation, hard to know. It could be a chicken and egg type problem, but nevertheless, the issue is that immunologically, these people have significant differences. There's a whole range of epigenetic factors, and I'll allude to this in a minute, but the BPAs, amongst others, perhaps influencing what we're seeing. And I'll allude to this in a minute, but it does appear around the world that endometriosis is possibly becoming more common, occurring at a younger age, and we are seeing more and more severe sort of disease. So we're seeing sort of, bowel involvement in people in their sort of their 20s, which, 10, 20 years ago was sort of really unheard of. And again, I'll allude to that as we go through the talk. It's strange, and nobody has quite worked out why, but people with endometriosis tend to have a low body mass index, and it's sort of inversely related, so that you would expect that, people with higher body mass indexes with higher estrogen levels would have more endometriosis, but the reverse is the situation. And we're not quite sure what that may allude to. I sort of alluded to this inflammatory problem before, and it may be that endometriosis affects the metabolism of the liver and adipose tissue, leading to sort of systemic inflammation and alterations in the brain with increased pain perception, anxiety, mood disorders, which is all exceedingly common, as all of you are aware, I'm quite sure. I alluded to the sort of the irritable bowel syndrome issues. So in the investigation of patients with irritable bowel syndrome, all of those tests look on the inside of the bowel, but none of them really look at the outside of the bowel. And so, there's a big overlap, and we looked at this some years ago, and it's exceedingly common for people with endometriosis to also have sort of irritable symptoms that affect the bowel, and they get late targeted as irritable bowel syndrome. That's a condition which, as you know, is there's a whole pile of tests that are done, but it's a sort of a diagnosis of exclusion to an extent. But I think endometriosis is going to be a big trigger for quite a significant number of those people. This disease is associated with a whole pile of other chronic diseases, so cancer, ovary and breast. In particular, the ovarian tumours they occur in the phenotype of people who have quite severe, sort of deep invasive endometriosis with bowel involvement and ovarian involvement. And interestingly, and I'm not sure why, there is an association with melanoma. Autoimmune issues I've alluded to before, so it's very common for people to have, say, thyroid problems, asthma, other issues, but also cardiovascular, neurological, and, as I've alluded to, sort of inflammatory problems. A Canadian paper just recently, within the last few years, has indicated what we've sort of thought for some time, and that is of patients, the phenotype of patients who have deep invasive disease and true deep invasive disease, they have possibly up to 10 times increased risk of the development of ovarian cancer as they get older. It's a bit hard to know what we should do about that, but in my own practice, what I've been doing, and I now have a reasonably large cohort of people like this, I just sort of monitor them until menopause. So 10 times the background risk sounds bad, but ovarian cancer is actually pretty rare. So if you multiply a small number even by 10, you've still got a reasonably small number. So I think it's reasonable to take the benefits of the hormones that accrue from having your ovaries until menopause. And then at menopause, contemplate whether you might do risk-reducing, prophylactic oophorectomy. Understanding, of course, that between now and I'm not sure over the next few years, it's highly likely we're going to have genetic testing, other ways that we'll be able to differentiate those people who are truly at risk versus the people who aren't. But I think at the moment, I acknowledge it, but I try not to sort of get people to be overly concerned and worried, and just sort of monitor them. This does appear to be a pregnancy-related problem as well. So if you have endometriosis, you are at increased risk of miscarriage, ectopic, hemorrhage, prematurity, growth retardation, hypertensive disorders, preterm delivery. And so it may be that endometriosis is actually quite a significant pregnancy risk, which I'm not sure is quite well known, but it's certainly correct. There's an interesting sort of view that it may be that endometriosis, so humans require deep placentation for successful pregnancy. And if you get pregnant in your first 1 or 2 or 3 sort of menstrual cycles, you haven't sort of pre-prepared the endometrium. And it may be that endometriosis somehow through nature somehow prepares that so that you have less pregnancy problems in your first sort of few pregnancies when you get when you first get pregnant. Jan Brozens in Brussels has sort of propagated this sort of theory. It's an interesting view. I'm not sure, but what it sort of suggests is that endometriosis may, in fact, not be a disease per se, but some sort of protective issue for pregnancies in humans in your first few cycles. But then, as you age, if you don't get pregnant in your first few cycles, which is clearly the way most of the Western world works, then it becomes highly problematic. So it's a sort of an interesting theory, and it may explain why we've had such difficulty working out what this disease is. Because if it's sort of a variant of nature that proffers some benefits at some point, but then at other points becomes a problem, then it's been very difficult to tease it out. I'll move on to so when I sort of see people, I really think that you need to sort of individualize management for all these people. So they will have specific issues, be it pain, fertility, a mass, or whatever. So you need to look at all those sort of things. That becomes particularly difficult with fertility. The sort of fertility world has become highly corporatized, and I do a reasonable amount of IVF, but it's if you have endometriosis and you end up in the wrong hands, you can go down a pathway that may not be good for you. And so, the Australian view of, if your only solution is a hammer, then every problem becomes a nail, is sort of correct. And so I clearly think that, whilst fertility is an issue, looking at sort of IVF versus surgery versus medications or whatever, it really depends on who people end up seeing as to what their management is going to be. So my four pillars that I look at is either pregnancy or pseudo-pregnancy, which is some form of hormonal manipulation, inflammation or anti-inflammation sort of measures, pain control, and then finally sort of surgery. So I don't really put surgery as the primary sort of point, but it's an important thing, but it's certainly not the only thing. In terms of sort of pregnancy medication, clearly there will be people who want to get pregnant, and if they can get pregnant, for a lot of those people, that will be great and be sort of almost definitive treatment, but not for all. And some of them obviously will have difficulties getting pregnant. As far as medications are concerned, something like a third of patients don't respond to the contraceptive pill. It may be that they've got some sort of form of progesterone resistance. Mirena in the literature has been an excellent sort of adjunct, but it's not for everybody, as you all know. It takes 3 to 6 months before you get the full effect. There's issues with irregular sort of spotting, and then sort of pain as it first goes in before you get the full effect. You'd be familiar with the various progestogens. Dynagest may be sort of unique in that it might overcome sort of progesterone resistance, but we don't really know the answer to that. What I've done in a lot of people, and I did with sort of Ian Fraser sort of years ago, was to imagine that endometriosis is a little bit like cancer in the sense that, when we treat cancer, we may use chemotherapy, surgery, radiotherapy, and then of the chemotherapeutic agents, we may have a number of other agents. And there's a sort of a symbiotic effect when you add some of these treatments together. And the same thing happens with endometriosis. So I don't think there's any problem at all with adding agents such as, for example, Mirena plus Implanon together. And for a lot of people, that can be a sort of a godsend. It's a great way to go. There's some new agents on the block. So Reiku, which is a GnRH therapy plus add-back treatment. And that's sort of new. I've only just sort of started using it, but the results early on appear fairly encouraging. I suspect most of you may not have had use of this sort of agent, so I thought I'd add a few bits and pieces here about it. But it's really sort of it's new. It's a variation of sort of old sort of therapy, and it's been propagated for use in symptomatic treatment of patients with significant endometriosis, and it's listed on the PBS, so you can use it. It's an antagonist, which means you don't get any sort of flare-up as you start it. It starts rapidly. It's oral. You can stop it. And the studies, whilst there's a sort of theoretical risk of long-term effects in terms of bone mineral density scan, doesn't appear that it's a big problem in terms of what's happened with the trials to date. And what we're trying to do is get the estradiol into a sort of therapeutic sort of narrow band, which then hopefully decreases side effects, some menopausal sort of side effects, so headaches, mood issues. That's the sort of the plan. There's been like a big sort of trial that was done, and the results pretty encouraging in terms of rapid decrease in symptoms. And these were different arms of the trial looking at relugolix versus a placebo, and then adding back sort of hormone replacement therapy, estrogen, progestogen, such that a significant number of people seem to do very well. Where this is going to land in the sort of the larger scheme, I don't know, but I think it's going to have it will definitely have a place. So sustained reduction in pain, improvement in daily activities, decreased need for analgesics. I sort of alluded to this being an inflammatory problem. And so now I sort of talk to all of my patients about this. And I think it's really important that patients can become their own sort of, that they can take sort of control, ownership of some of their management themselves. A lot of people will already be doing some of these things, but I think it's incumbent on all of us to sort of stress, so diet, weight, exercise, acupuncture, mindfulness. Sleep and stress are huge deals. So when you're talking about any sort of chronic condition like endometriosis, if you're not sleeping very well, if you're stressed, then that's going to make massive issues in terms of your capacity to cope with symptoms and your whole hormonal sort of profile. There's a number of supplements, so turmeric, N-acetylcysteine, and pycnogenol. So these things, particularly for the people who have bowel issues, I think these are great additions, and I've had a lot of success with suggesting these sort of agents to a lot of people. There's studies relating to some of these agents, N-acetylcysteine, for example, in terms of ovarian endometriomas, fertility outcomes, and I think the downside's pretty low. So, I think there's plenty of upside, and if people do gain sort of some assistance with this, I think it's a great thing to utilise. There's been some recent talk about the microbiome and the gut of people with endometriosis. The suggestion being that maybe they have a slightly different sort of microbiome, and maybe some of them have some form of sort of leaky gut. And under those sort of circumstances, sort of bacterial fragments, lipopolysaccharides, get through across that sort of gut wall. They get into the peritoneal fluid. You get this activation of the immune system, a low-grade systemic inflammation, which then sensitizes nerves. So you get central and peripheral sensitization. And this effect can perhaps persist after these lesions have been excised. And so people have ongoing issues, with pain and lots of other symptoms, and bowel symptoms in particular. I'm not sure, where this lands, but I think looking at the gut microbiome and trying to optimize that is a good thing. And I've certainly had, some very good stories back from people and patients who've looked at this. As we know, bowel, bladder, and pelvis all share neural sort of pathways. So it would make sort of sense that if you've got an inflamed gut, you can get sort of spillover effects with sort of subsequent pelvic pain perception. And this might explain why a lot of these people get sort of these irritable bowel syndrome type symptoms, these food triggered flares, and bloating and visceral hypersensitivity. Very interestingly, there's been talk recently, certainly amongst a lot of patient groups, that the GLP-1 receptor agonists, the Ozempics of this world, seem to have, for some people, a very significant effect on symptoms. So I've now seen quite a few patients who've been on these agents, and they report dramatic improvement in symptoms, but both pain and inflammatory symptoms and bowel symptoms. So it may be that these agents, well, they do reduce inflammatory cytokines. They seem to lower inflammatory markers. They may well improve sort of gut barrier integrity, decrease this endotoxin-driven inflammation, and reduce sort of like I guess a pain amplification. I'm not at all suggesting that we should race out and be prescribing these agents for people with endometriosis. But if you do come across patients who happen to have both endometriosis and taking agents like this, it's interesting to have a chat with them to see, if there is an effect. It's not universal. So I've certainly seen quite a number of people who have no effect, but it's striking the ones that seem to do have an effect. This is the sort of diet I would suggest that patients look at, and can't quite see because my screen's in. I'll drop this, but these. So this is the sort of thing that I would suggest that patients look at. And on the sort of bottom right, those vegetable oils, they're sort of the things that they really should avoid. So whilst they're sort of put out as sort of friendly and good, I think that the reverse is actually probably true for people with endometriosis. So these seed-based oils, they're high in MDA and 5-hydroxy-nonenal, which interacts with DNA, has the potential to increase cancers. It's neurotoxic. There's issues with Alzheimer's, motor neuron, macular degeneration, arthritis, etc., etc. They appear to decrease sperm count and quality, thus potentially having an effect on sort of pregnancies and offspring. Does it have an effect on endometriosis? Hard to know, but at least in rats, if you alter some of these agents, then you do seem to have an effect. So I think it would be sensible to suggest to people that they try and avoid these sort of agents. In terms of pain, that's a whole sort of region on its own. I think broadly, the vast majority of people who have endometriosis will have a sort of a tightened levator floor than most people. So pelvic floor physiotherapy we find exceedingly useful. It's not for everybody, but I think for a large number of people, it can be exceedingly useful in terms of symptom control and helping people with, getting on with their life. I've recently been reading about sort of pain issues in a chronic pain sort of setting. So humans are designed to sort of anticipate and then automate. So, we think what might be happening in a chronic sort of setting is that a patient will get a sort of a sensation that's, say, a 2 out of 10, and then they will automatically think, well, look, I've had this before. It suddenly gets really bad. So let's just tell the brain it's really bad now. In other words, you get this inappropriate sort of signaling, and they become, in essence, sort of hypersensitive to pain. They can have this sort of central pain sensitization. You can sort of imagine or think about it. If you think about, say, if you get a full bladder and you have the sensation that you need to pass urine, if you hold that sensation in and you don't pass urine, then you lose the sensation. You can push it out down time, and then the sensation will come back again. We think the same thing can happen with pain. So there's a video on the top right that Tame the Beast, and there's a number of other books sort of outlining some of these sort of issues. And I think it would be useful for patients in particular to have a look at this, and perhaps the audience to sort of look at some of these concepts, because I think this is, really starting to get to the nuts as to why we're having it so difficult to control pain for a lot of these people. I'll just move to diagnosis. So there's a whole pile of different biomarkers that have been looked at. None of them are overly sort of useful at the moment. CA125 sort of, it gets elevated, but doesn't really help us too much. But ultrasound diagnosis can be exceedingly useful, but it's very, very operator dependent. So you need to have technicians, doctors who are skilled in these sort of techniques. Luckily, in Sydney now, there's large numbers of people around who are capable of doing this. It's a little bit frustrating that they will do that. It doesn't happen sort of automatically. It's not automated in the sense that if they pick up someone who's got an endometrioma, who then is likely to have significant disease, it would be great if they could go on and sort of offer it straight away, but they need the sort of the technique and the time to do it. So unfortunately for a lot of people, it tends to be a two-stage procedure. In the absence of the capacity to do a scan looking specifically for deep invasive endometriosis, you can use MRI. And for people who can't, for whatever reason, tolerate a transvaginal ultrasound, that's useful. They're very similar, but MRI is clearly a lot more expensive. If you do see a patient who has an ovarian endometrioma, then you need to be wary. The smaller ones, they tend to be overcalled. So if you see a scan that's got say a 15 millimeter or 10 millimeter suggestion of an endometrioma, it's probably not an endometrioma. Most of those tend to be overcalls. If it is a true sort of endometrioma of several centimeters, then these people, they're highly likely to have extensive disease, and not uncommonly, the cul-de-sac and the bowel will be involved. And these are the people who would very much benefit from, DIE sort of scanning. I just make the point that it is difficult to understand the disease unless you've seen sort of excisions. So the way the disease works is that it creates a sort of a highly inflammatory desmoplastic reaction. And if you feel the tissue involved, it drags all this sort of associated surrounding tissue in, and you get this an inflammatory reaction that can be sort of like concrete, so it can be super hard. And when we remove it, then you can be left with a large sort of defect. And that's the way it sort of evolves. Here, it's sort of interesting. I've got a patient who, on the right, it doesn't sort of look too bad, but when you lift up this area on this right uterosacral ligament, you can see there's a big, huge nodule of endometriosis, which is that sort of white area on the right. I sort of alluded to the fact that over the years, my colleagues and I around the world, at meetings and things, are coming to the conclusion that this appears to be happening in younger sort of patients and appears to be more severe, which suggests that there's something in the environment that's going on. We wrote a paper sort of years ago, and we wrote up 177 cases of bowel involvement back in sort of 2009 or in the early 2000s. And there was this chap, Graham Dennistein, who wrote this letter and sort of saying, look, he'd been a gynecologist for 41 years, and he'd only ever seen one patient with bowel involvement. And so has been this sort of reluctance to look at it and then sort of manage it. But I think also it's probably real that we are seeing more and more patients who we just didn't see before. As I said, why that is, I don't know, but I suspect there must be something in the environment that's doing this. There's a whole pile of surgical issues. So and one huge problem is that it's quite clear that you can have occult or microscopic disease. In other words, we take a sort of a random biopsy somewhere, which looks normal, but then we get back, microscopic endometriosis on the histology, which makes it sort of seriously difficult. There's major sort of staging problems. So there's multiple staging systems, and that creates a huge problem. I'll allude to this in a minute, but the bias is for patients to have a high stage disease, so because that sort of validates their symptoms. So if they have severe symptoms and you say, look, you don't have much disease, that's sort of pretty discouraging. But if you say, okay, look, you've got really bad disease, that explains your issue. But it sort of just doesn't work like that. So that becomes a problem. And for the surgeons as well, particularly in the private sector, there's a bias to find sort of high stage disease because you get a sort of a different sort of fee for that sort of surgery. So I think that there's a huge bias to sort of overcall that stage. There's a huge amount of bias in terms of the surgery. As you would all appreciate, it's not like a Big Mac out there. They're not all the same. So the skill of the surgeon has a major issue. It's the same as with cancer surgery. So that's been looked at sort of in multiple specialties, in multiple disciplines, and experience is really a major sort of issue. This disease does not obey sort of anatomical boundaries, which means you suddenly need the involvement of surgical colleagues in other disciplines, colorectal surgery, urology, sort of upper GIT, to name just a few. I alluded to sort of the bias just a minute ago for both the patient and the doctor to upstage. Some of you would be aware of events in Melbourne in the last few months where a surgeon appears to have tremendously upstaged a lot of disease, and ultimately there's been a huge sort of number of people who have been left with sort of major problems. This particular surgeon's in all sorts of strife, and I think rightly so. But the endometriosis, unfortunately, it's not like sort of taking your appendix out or your gallbladder. And there is the potential, unfortunately for me to say this, but there's a potential for a degree of fraud to occur. I've just looked at my sort of numbers over the last sort of 12 months or so, and most of what I do is see people with endometriosis, and of that, most of them have got reasonably significant disease. But even then, there's different item numbers we would use for the stage and the complexity of what we're doing. So, I only call true stage 4 disease something like 26% of the time that we operate. Okay, maybe up to 50% is reasonably significant, but there are units out there where, everybody they see is stage 4 disease, and that cannot be correct. And it creates huge issues in terms of the subsequent management of these people, because, they think they've got one thing when in fact they've got something else. And I find that sort of difficult to deal with. So you should be aware that when people are talking about stages, it's a little bit like looking at the Mona Lisa. Is that a good painting or a bad painting? It's very hard to describe it. So I would think that you should at least take some consideration of that when you're talking to patients. It's not always easy to make a diagnosis, and it's surprisingly easy to underdiagnose substantial disease. So you can have significant deposits which can stretch sort of, like an iceberg under the surface. And that can create sort of significant problems in terms of, symptom control, surgical extent of involvement. And as I alluded before, this microscopic disease, which also creates sort of more problems for us. These are just some random shots, just, I guess, demonstrating this inflammatory nature of the disease. So top left, we've got, normal. So this ball of muscle is the uterus. This cylinder here is the cervix, top of the vagina, little tube, white ovary, and there's a uterosacral ligament here, and the bowel down here. So here's someone, you can sort of see this inflammatory component. So, these people it can almost at times look as though they've got pelvic inflammatory disease because there's just so much going on. And it's no wonder they've got such terribly painful sort of, symptoms as a consequence of this. Conversely, you can have scenarios like this. So here we've got, if you look on the bottom left here, these are little deposits of endometriosis on the small bowel. And we're talking, so that's 5 millimeters, this sucker probe here. So, 2 to 3 millimeters, what do you do about that? You can't chop it out. You'd need to do a segmental resection if they've got this over a longer area. And more of the same here, here's more on the right. Another lesion here. So I'm not sure what we do with these people, whether you can sort of manage it, but you could understand that if they've got this irritative, inflamed area on their bowel, they're going to have bowel symptoms. And clearly looking on the inside of the bowel is not going to diagnose that. I want to spend a few minutes on this slide because this is material and really, I think, goes to a lot of what happens with a lot of surgery. So forgive me if it's sort of surgically orientated, and I appreciate that none of you will do a lot of this, but on the left, we've got a normal sort of view. Top right, this is the bowel. You can see the muscular component of the bowel, and it's adherent to the back of the uterus. So you can see a white ovary here, another ovary there, a bit of a tube, but you can't see any of the cervix and you can't see any of the top of the vagina. Here we've operated and we've basically removed the base of the pelvis. So there's about a 20 centimetre area that we've removed, both side walls of the pelvis. So the incision line runs around here, sort of a bit like a large butterfly, and then across on the other side. So now we can see the cervix here. There's a 90-degree angle, which is our manipulator in the vagina, and this tube here. So we've removed the disease. I've seen now a lot of this situation where, again, normal top right, here we can see bowel stuck to the back of the uterus. You can't see cervix, you can't see top of the vagina. They've had an operation, they've exposed, okay, here's a left ureter, right one's over here. But you can't see cervix, you can't see top of the vagina. So the endometriosis is still there. It's acting sort of like super glue between top of the vagina, back of the uterus, and the front portion of the rectum here. So it's all still adherent. So the disease is still there. And they've sort of said they've removed it, but in fact, it's still there. Just a few words about robotics. So the robotic platform, which I've been using for sort of 5-6 years or so, is really it's a game changer in terms of the capacity to dissect. And by that, I mean, so endometriosis dissection is really sort of key. You need to be able to get into these planes to safely remove the disease. And the robotic platform is a fabulous way of doing that. I tell patients if you imagine the difference between peeling a ripe banana versus a green banana, the robots help us peel the green bananas, and it's a great thing, especially for the more severe forms of disease. So here's just some robotic images taking out some terminal ileum, appendix that's all caught up onto that right adnexa. I'll just sort of run fairly rapidly through this, but here's somebody who is this going to run? Yeah. So there's a whole pile of issues in terms of if you do have involvement of the bowel, clearly you want to have minimal sort of the more conservative procedures, the best. Around the world, presumably for the same sort of disease, there's a massive variation between people operating and doing a disc excision or just a rectal shave versus a segmental resection. Segmental resections are pretty morbid sort of procedures. So if you can avoid that, it's much better. But for some reason, there's different units who will do large numbers of segments, whereas others will do sort of much lower sort of numbers. And I think that it depends on the experience of the gynecologist. So if the gynecologist hasn't done a lot of this and they get the colorectal surgeons involved who do more segmental resections, then you're going to see more segments rather than discs. But I think discs, for the vast majority of people, are a much better way of going. So this is just some examples of some rectal resections, and you can see that anastomotic line there. This is involvement of the bladder, so you can see this clear, obvious lesion here. On the right, underneath, there's cystoscopic views of endometrial tissue within the bladder. Here we've got a fold of bladder that's caught to the back of the uterus. with all this adherent area. We've removed this section of bladder, so here's our Foley's catheter, and then we've sort of repair it. You can get involvement of the ureter. So here's a big sort of swollen ureter right on the right side. We've got all this inflammatory, phlegmatic sort of issue obstructing the ureter. It's usually at the site of the uterine artery. So here we've removed the obstruction, and then we've put like a stent. Interestingly, this patient, this ureter was so dilated, it sort of done an S bend above it. A lot of these people, it depends on where they go and what happens, that a large number of them can just have a urethrolysis rather than a reimplantation. Sometimes you do need to do a reimplantation, but for the most part, they don't need to. This is pretty rare, but you can get it in the liver. So this is a segment of somebody we removed, years ago. This was sort of bordering on a sort of a malignant sort of process. Getting the diaphragm. So here's areas here. Here's another area near the superior vena cava, which is highly problematic. Here, this is a lesion I alluded to before in the diaphragm. So we're operating through the chest. So these are the bones, the ribs. We've taken this big chunk out and then had to put a mesh repair in. Just a few words about adenomyosis. So adenomyosis, look, this is becoming more common as well. Again, we don't really understand this very well. It can be difficult to diagnose. So you may have different ultrasounds saying you do or you don't have adenomyosis. MRI might be a better way to diagnose it. For those patients who are looking at sort of fertility, it becomes a real problem. And in the sense that, it can be terribly difficult to deal with it and manage it. And particularly if you're trying to get pregnant, all of the treatments for this are going to be sort of contraceptive, and surgery, ultimately involves removing the uterus. There have been sort of heroic attempts to try and sort of piecemeal remove adenomyomas and leave the uterus behind, but there's no sort of tissue plane, and you can render yourself with a sort of a non-functioning uterus. So it's sort of difficult. Some of these people you may need to down-regulate with some sort of GnRH agonist or an antagonist, to hopefully get things under control. And Ryuku, which, whilst it has not been approved for this indication, is probably going to be quite a good agent. I'll just finish with a few words on fertility. So broadly speaking, if you look at patients, this is Rob Jansen from years ago, who was one of my mentors. If you look at sort of donor cycles in relation to patients with endometriosis versus patients who do not have endometriosis, the fecundity or the pregnancy prospects of the patients with endometriosis is significantly more compromised. And broadly, there's a sort of a stage-related effect. So not unsurprisingly, the more severe your endometriosis, the bigger the hit to your fertility prospects. Here's where it starts to get complex. So, and we don't really know the answer to this, and the literature's fairly contradictory. So I'll just sort of run through this reasonably rapidly. But there's been older sort of studies suggesting there's big issues in terms of getting pregnant with IVF. But the difficulty is operator skill, surgical bias, and commercial IVF has meant this world is hard to sort of understand. So some people say there's no difference in egg quality. Others suggest there is. There's a reasonable number of data to tell us that if you have endometriosis compared to people with unexplained infertility, then these people will get fewer eggs, lower blastocyst transfers, and decreased, implantation rates. If you remove, certainly in milder forms of endometriosis, the endometriosis, you will improve your subsequent IVF outcomes. It becomes more difficult in the higher grade areas, and so we're not sure. So there's this big sort of debate in the IVF world as to whether we should or shouldn't operate, with some data telling us that, look, if we operate, we're going to improve the prospects. Whereas if we don't, it's not going to make that much impact if you go straight to IVF. That's led a world where, somewhat bizarrely, if you see fertility patients who are trying to get pregnant and have pain, they will end up in a world where they may have repeated failed IVF, their pain gets worse, and as time goes on, that becomes highly problematic. So you need to very much individualise these sort of people. Yeah, more of the same in terms of the sense that I'm really not sure where we should be going with this. What I tend to do is look at sperm quality and symptom issues, and then put it to the patient. In my world, IVF's pretty good. It's been around for a reasonable length of time. However, we don't know anything about the next generation of patients. So, in other words, the IVF conceived patients and then their children. So that's a bit of an unknown. There's a sense that perhaps there's an increase in aging, perhaps there's some increase in terms of tumours and things, but there's a trade-off between that unknown versus the risk of a complication or major complication. So that's what I sort of put to patients, and plus symptoms, to work out what we're going to do. I'm sort of in this camp or sorry, not so much in this camp, but we're involved in the study at the moment, looking at this to try and work out, is there an issue or not? The current sort of literature tends to suggest that there's no difference in outcomes following IVF if you do or you don't operate. I think that's significantly sort of biased. This is more to my sort of thinking, in the sense that we seem to improve IVF outcomes if we clear endometriosis. And I think what we're doing is we are decreasing that inflammatory load, we're optimizing the pelvis before then looking at embryo transfer. And I think it relates not so much to the stimulated part of the cycle, but the transfer point. And it does appear that if you transfer an embryo if you do a frozen cycle as distinct from a fresh cycle, you seem to have better outcomes. All right, I might sort of wrap up there as we're getting sort of near 8:30. Broadly speaking, look, this is a complex disease. We don't really understand what it is. I do think there's definitional issues, and that therefore expectation management is a major problem in relation to patients. I think we should think about it as a chronic systemic inflammatory condition. There are significant numbers of surgical issues in terms of the extent of disease, the expertise of the surgeon, skilled teams that are required to run it. Pain management is a major issue. Ongoing management sort of following fertility, particularly with things like adenomyosis. Advanced disease does significantly impact both spontaneous and IVF pregnancy rates. And I do believe that we should individualise management with excision and then either pregnancy or some sort of pseudo-pregnancy. And we do have sort of new, sort of promising sort of therapeutics, Rico, those Ozempics and that sort of thing of this world. I guess that's a space that's, we wait to see where that ends up. Happy to take some questions and sort of have a general chat. But thanks for listening.
Oh, thank you, Professor Cooper. That was a very comprehensive and really interesting talk. No, that's fantastic. Got a little bit of time. I just wondered your experience. I know that endometriosis has increased pelvic pain presentations. Could you give us some tips when we see patients with pelvic pain, just how you approach that, or so as far as history clues or investigations in patients we don't know if they have endometriosis or not, sort of thing?
Yeah, look, as you would all appreciate, this is a hugely difficult sort of world, and there's so many layers of issues that you need to unbundle in relation to it all. And it's sort of like, again, that you'd want to sort of individualize it, but broadly it sort of depends on the age of the patient. So if patients are in their sort of teens, early 20s, and they've had it sort of from the get-go, then they've probably they're going to have one of sort of two or three things. Either they've got sort of primary dysmenorrhea, whatever that is, which is probably some sort of um, spasm of the uterine muscle. The uterus, of course, is capable of pushing babies out. So to a certain extent, it's one of the biggest muscles that you've sort of potentially got in your body. And if it goes into inappropriate sort of spasm, then, it's terribly difficult to sort of manage that. And obviously, and those people post pregnancies will improve. Um, there's a whole range of people who will have endometriosis, and it's very common. I'm in terms of investigations, I think you need to do some form of imaging, even just abdominal ultrasound. So there will be the occasional patient who's got some sort of Müllerian anomaly and will require some form of, surgical management. That's pretty rare. Um, I'd say a few words about sort of laparoscopy for the particularly young patient. So for some of those patients, you won't be able to do much in the way of imaging. And I have a problem in the sense that we don't really know the natural history of endometriosis, but it's notable to me that in the younger people in particular, they can have a variation of endometriosis where they will have sort of almost like a field change effect. So that if you look into their pelvis, they'll have sort of widespread, sort of smallish, sort of superficial areas. I don't think, and so you might take a biopsy and get a diagnosis, but you're not necessarily altering things, and you're not necessarily making, a huge amount of impact. So I would treat those as provisionally that they've got endometriosis. Personally, I try and actually put off operating and doing laparoscopies on younger people, particularly in their teens, because it's a very, very few patient is going to have, a significant nodule of endometriosis where surgery is going to have a big sort of impact. So I think in those people, you need to be looking at a whole pile of other things, inflammatory issues, potentially sort of, pelvic floor physiotherapy, and then sort of hormonal agents if you can do it. But they are, it's an exceedingly difficult group to deal with. I completely understand where your question is coming from.
The question about 16-year-olds and criteria sort of thing as far as diagnosing, it's very difficult. And the other thing is a lot of people that age and other ages and young adults who aren't sexually active or don't want the transvaginal ultrasound, as you mentioned, how accurate is it going to be having an abdominal ultrasound? To what extent are we going to miss things?
You're not going to find, well, all that you will find with an abdominal scan is, do they have some sort of, Müllerian anomaly? It's pretty rare, but you can see big endometriomas, in young women, and that's a disaster. Those people are likely to have significant, disease. They're going to have, premature sort of ovarian compromise, but they are the ones who probably should be managed more aggressively.
Oh, thank you. And you did mention about ultrasounds and being operator dependent. Would you mind telling us what ultrasound places that we can refer to that have specialisation in gynecological ultrasound? Sort of.
Well, I guess depends on where locally you are, but Sydney Ultrasound for Women, Ultrasound Care, Omni are three groups that are run by specialist obstetricians. And I think that their scans are getting better and better. They have, I guess they can have a tendency to overcall things a little bit, but it's remarkable how good they've become.
And should we be sending patients first off to those places if we suspect endometriosis, or should they just get a normal one locally first, which are a little bit cheaper, if that's
Uh,
for them?
yeah, look, it depends a little bit on the age of the patient. So, as a sort of a general guide, if you see somebody who's, say, less than 22, 22 to 25, you could see things, but under 22, exceedingly unlikely you're going to find anything on a deep invasive scan. Um, and they're very unlikely to have sort of significant disease. And I'd also point out that it might be that for some of these younger people in particular, they could have a form of endometriosis that can sort of come and go. So it's not at all clear or um, or well established that endometriosis necessarily gets sort of worse with the passage of time. And I liken, I get the sense that in younger people, you can have a version of endometriosis that, as I say, is sort of widespread, a bit like a field change effect. It's a little bit like if you imagine sort of an oil slick out in the middle of the ocean, it can be spread over a huge area. But then as you get older, it sort of tends to get concentrated. So we see that sort of more superficial, sort of widespread effect much less as people get older. And it's more like, that oil slick sort of washing up next to the side of a landmass somewhere, and it gets sort of concentrated. And so therefore you see sort of in the 25 plus, people tend to have a more nodular, concentrated sort of degree of endometriosis. And that's good because from a surgical perspective, if you've got sort of an isolated sort of nodular area with anatomical distortion and you excise that, they're likely to do very well. Whereas the people with the more superficial, widespread sort of change, even though they might stage high on some of the staging systems, they're not going to benefit much from surgery.
Well, thank you. And for the young patients that we do see from 16 to 20, noting that just what you mentioned, that it doesn't always sort of show up on examinations if we can do one or scans, what first line, if we suspected otherwise, and there's a normal ultrasound, should we be putting them on the combined contraceptive pill, Slinda, just starting off with NSAIDs early?
Yeah, so what I tend to do is I say to them, look, I think you've probably got endometriosis, and I utilize that as a sort of a working diagnosis. And what I then use is, sure, mainline oral contraceptives in the first instance, um, Slinda, some of those sort of agents. And then if we're not getting anywhere, okay, my hand might get forced and we might be, and not uncommonly they're with their sort of their mother or their parents who are sort of pushing to have things done. And you can get pushed into a world where somewhat, what's the word, unenthusiastically, I might be pushed to do a laparoscopy. But almost invariably, it doesn't change the deal much. And then I would move to say agents like some Visane. I think Marina's still pretty good. Marina plus Implanon. Um, I haven't used Rako in sort of particularly young people as a first line at this point of time. I might contemplate doing that at some stage, but I'm not there yet.
Yes, someone's actually just asked what the role of Zen in medical management of endometriosis is, if you can elaborate on that. And also, now it's PBS, and we're seeing more usage. Also, any side effects or other things we need to know about in patients on Visan?
Um, Zen seems to have less mood effect than some of the other sort of progestogens. It's for most people, it's pretty reasonably well tolerated, but as you know, there's a group of patients who they're just intolerant of almost everything. And those people, that's really difficult as to what you do next. I don't have any magic there, I'm afraid.
Would you be using that sort of after contraceptive pill or
Yeah, yeah.
Norems or
As,
Implanon?
as I said, I think there's a degree of progestogen sort of intolerance, um, and if you're not, well, what I also tell people is that at some point you might have to pick rather than the best option, they might need to pick the least worst option. In other words, what's the agent that they can sort of live with, which makes their life sort of tolerable. Um, so I would use, contraceptive pills in the first, or non-steroidals and those agents to start with, contraceptive pill, Slinda, and then move on to Visane. And I try to be encouraging them to at least trial it for several months. So there's a large number of people who they will use these agents for less than a month, and you don't know whether they work or they don't work because they just haven't given it time.
And someone's mentioned about Ryeco. Is it indicated for women? It's indicated for women of reproductive age, but should they stop that and how far ahead, if they're planning a pregnancy, is there any sort of pre-pregnancy issues with endometriosis and the treatments we need to know about?
I don't think so, no. I think it'll wash out pretty rapidly, and then you can get pregnant. So I don't think that's a concern.
Right. And I think NSAIDs, you've mentioned previously that can affect ovulation. Is that right? They stop them if they're going to try
Yeah,
to get pregnant?
yeah, they're sort of unfortunately they're mildly contraceptive, so they can inhibit ovulation.
Uh, and there's been a lot of theories, as we know, in the papers and the Herald about medical misogyny and about doctors and GPs particularly missing endometriosis. But with the increase, availability of better ultrasounds and increased knowledge and education about endometriosis, do you think medical misogyny is now a thing of the past? Someone who's asking it sort of said that she basically had endometriosis, but at the time her gynecologist sort of said, "Oh, look, it's all in your brain. You must be stressed," or something like that. Do you think
Uh,
that's sort of decreasing now?
oh yeah, I think I look, the whole the starting point is we don't know what this condition is. So I think it's pretty difficult for, us to be called all medical misogynists because we can't automatically fix everything. Um, I just find that sort of, I got to say, somewhat offensive. I'm quite sure all of your audience are acutely attuned to some of all of these issues, and they're not trying to sort of negate people's concerns or their symptoms. Um, and it's difficult. And trying to differentiate the patient who's got, true endometriosis versus, say, the patient who may have, you know, the rolled gold standard laparoscopy, but no obvious endometriosis visible. However, on a biopsy, they've got microscopic disease. Well, it's super difficult to work these issues out.
And someone's asked, do the non-menstrual symptoms of endometriosis improve after menopause, like the bowel symptoms?
Yes.
They do. They're not lifelong, at least.
Yeah, yeah, yeah. So the problem with if you've got, so I've got a whole range of people who I see, who I just examine. You can feel endometriosis, vaginally at the posterior fornix. It extends into the rectum, but they don't have any symptoms. So we just scan them, keep an eye on them, and don't do anything. And then at menopause, the vast majority of people, their symptoms will resolve. One thing, I guess, if you are seeing patients who've had, say, hysterectomy and you suspect may have significant endometriosis left, then those people should probably have combined estrogen, progestogen therapy because they're sort of at risk of, potential malignancy.
Are there any clues? Because we see a lot of people with irritable bowel syndrome. Are there any sort of symptoms that we can distinguish from endometriosis, or should we routinely send IBS for ultrasounds?
Um, Great question. I mean, when I'm talking about this, a lot of patients will start nodding when they say, "Oh yeah, I've got all that." They've been told they've got irritable bowel syndrome, which they think is a separate condition. Um, I I think it's probably the same. There's clearly a cohort of people who do not have endometriosis, who have irritable bowel syndrome, and then there's clearly people who have, endometriosis and they have endometriosis associated irritable, bowel issues. How you differentiate that, I'm not really sure. Ultrasound, absolutely, I think that's a reasonable thing to do. And a careful history. So some of those people, they may not have a huge amount of pain, but they might have a lot of bowel symptoms and they might have, for example, premenstrual spotting, and that would be a clue. But yes, an ultrasound I think is completely reasonable.
And should we, in situations where we suspect it, should we be then asking, can they please do a special endometriosis sort of ultrasound, the ultrasound place
Yeah, I think so.
situation?
I
Yeah,
think yeah,
do
you'll
that
get
first off.
you will get pickups. Yeah, absolutely.
And is the pain from endometriosis always cyclical, whether it be sort of the period,
Um,
the other organ pain?
um, Broadly speaking, yes, but then there is a cohort of people who will move on to a more sustained sort of pain issue with a cyclical sort of component.
You have a good question. Is it helpful for patients to consult a dietitian who promotes exercise and anti-inflammatory diets for
Absolutely, absolutely.
endometriosis?
I
And
think there's, those inflammatory things. So I tell people, a lot of people are already doing some of these things, but I think the diet is really important for these sort of patients. And it strikes me that whilst these lifestyle measures on their own may not amount to much, if you add them together, you can have a big impact in terms of pain, of symptom relief. So, and I do think that for patients being able to take sort of control ownership of part of their own management is a really powerful thing to do for them.
it's interesting about that because I was reading an article today saying that the increase in bowel cancer in younger people, which has increased by 200%, they think it
Yeah,
might
yeah,
be related to inflammatory things and seed oils, as you were
yes,
into.
yeah, yeah, yeah,
Yeah.
yeah.
And so would most dietitians have that expertise about anti-inflammatory diets? Or,
Um, look, as far as I can see, the anti-inflammatory diet world is fairly broad, with no sort of clear consensus. Although I do note, as you've just sort of indicated, that increasingly people seem to appreciate that the seed oils are actually problematical and not as beneficial as was thought or as advertised, say, 10 years ago.
and if endometriosis settles in pregnancy, does it tend to recur just the same sort of after pregnancy? Because a lot of people think, oh, pregnancy will cure it.
A lot of people will improve with pregnancy, but not everybody.
And is Visane a contraceptive agent?
So Visane has not been tested and is not approved as a contraceptive, but it will be contraceptive.
And someone had a patient that reported side effects of Visane, including low libido. It caused hot flushes.
I'm not familiar with hot flushes in
I think that'd
Visane.
be rare quote.
Um, yeah, I haven't heard that before. Libido is a difficult thing to talk about, in the context of pain and endometriosis. A lot of people have low libido because they don't have sex because it's painful.
Mm. And we'd be using Visane after we used the contraceptive pill. That'd be sort of, and after we use the Marinas or Implanons, that'd be a third line anyway, wouldn't it? And then the next probably Rayco from what you're saying.
What I would tend to do, so if we had sort of someone, for example, who had marina and we weren't getting a lot of effect, rather than taking the marina out and removing it and doing something else, I'd probably add something to it. So I have a whole pile of patients who will use marina plus Visane or marina plus Implanon, for example. And for a lot of people, that works very well.
And someone's just asked that. Can you add Visane to Marina or Implanon?
Yeah, yeah, yeah.
Yep. And I just wondered that the RACGP put out a thing about 2 weeks ago saying in history about the SAFE score. There were different sort of scores, questions that we can ask patients. I didn't know whether you thought that it still hasn't been validated by the sound of it, like things like how often they get pelvic pain, if they've had treatment for it, have they taken painkillers for pelvic pain, that heavy menstrual bleeding, painful periods, or a family history of endometriosis. It was like a 6-question thing that they were trying to sort of get clues in the history so we can better diagnose or suspect endometriosis. I just
It's a
want
difficult, I think you alluded to that. I'm not familiar with that. I can understand why people might want to be able to do that. There are a number of apps and things that people can use to sort of to try and work it out. A lot, and to a certain extent, a lot of patients have sort of researched it themselves, and they've sort of diagnosed themselves even by the time you see them.
yeah, and there was another one, the Endosure was
Mm.
I don't know if it's still being advertised. They're sort of trying to claim you put on your abdomen, you can get an idea if they've got endometriosis.
Yeah, I, I've seen that advertised. Whether it works or not, I'm not sure. I haven't sort of used it myself.
I don't know if that's particularly been validated very much either. So if
Yeah.
anyone's got any other questions, please feel free to put them in the chat. It was a very comprehensive talk, so I think you covered a lot of things like that. Do you want to elaborate? Does it cause heavy periods? A lot of the things like the
Uh,
scores just mentioned, then menorrhagia. Is that very
yes.
common in
So
endometriosis?
it's not. You can get a whole pile of different things. So I alluded to the premenstrual spotting, which I asked, which I mentioned before, and I think it's very much worth asking that as a specific question because if you get a pickup, it's highly probable that that individual will have endometriosis. Um, but in varying forms, as I alluded to, that endometrial myometrial interface is abnormal in people with endometriosis. So they can have heavy sort of bleeding that goes on for sort of longer, not so much intermenstrual bleeding, um, and not so much clotting, but they all can be features, yes.
Mm. And you also mentioned about robotics. And the importance also of referring to someone who has skills in endometriosis, in case something needs to be excised. What centres do the robotic surgery in Sydney?
What centres are, so Prince Alfred, St Vincent's, St George, pretty much all of them now. I've got robotic sort of, surgeons. Um, it strikes me it's just there's a capital cost involved. For patients who've got sort of more minor disease, I don't think it's worth it. But for people who've got big time sort of rectosigmoid involvement, ureteric obstruction, then very much it's worth it.
Mm.
It's a so, for example, we used to do, if for whatever reason we had a ureter that we couldn't deal with and it required reimplantation, then you can do a laparoscopic reimplantation, but it's a really finicky, difficult thing to do. Whereas a robotic reimplantation, we've just published a series on it, and you can do that with robotics, 60 under 90 minutes, and it's a beautiful operation. So I think for the big time disease, I think it's a game changer.
Mm. And also, can you just elaborate anything else we should know about adenomyosis? I know it's associated with it. I don't know that it sort of sounds like it in the myometrium, but I know
Yeah,
it's just a sort of disease rather than a cause and effect.
well, it's a bad diagnosis, and so well, I seem to be seeing it, and I'm sure you are as well, in sort of younger women. And the difficulty is, what do you do with those sort of people? I think if they're symptomatic, then contraceptive pills, progestogens, they might all sort of mask things, but they probably don't do much else. And it might be that Reiku is something that would be a good agent for those sort of people. But, I sort of suggested to them, look, this is not good. So if you can readjust your sort of lifestyle, calendar in terms of conceiving, bring that sort of forward because, you know, some of those people will end up with hysterectomies.
Someone's written here, endometriosis can spread like cancer cells. Has it ever been considered to use chemotherapy to control the disease, as long as you use an agent that doesn't destroy your ovarian function, of course?
Not that I'm aware of.
Mm, because it's sort of increasingly, certainly spreads. The one in the liver certainly looked like a
Yeah.
nasty tumor, didn't it? Yeah. And with
Oh,
Bizan,
yeah. So that was sort of hyperplastic.
mm,
Yeah.
a lot of difficult surgery. I think take a lot of skill to get that out safely.
Yeah, absolutely.
With Bizan, can patients often get sort of bleeding on it paradoxically, or does it take a while to cause amenorrhea?
Um, it's usually pretty quick. I mean, it's not like there are people who sort of bleed through it, but vast majority of people become amenorrheic pretty rapidly.
Right. And is there anything you'd like to tell us about any of those things that you see from GPs, whether it be endometriosis or pelvic pain or dysmenorrhea, that we should be doing or we might be missing, or any sort of things from your point of view that GPs need to know or should know?
Um, Look, I think that you're all doing a fabulous job, to be honest with you, in a world that's becoming increasingly difficult, in a group of patients who appear to becoming sort of more and more demanding and more sort of difficult to deal with. So I sort of congratulate you in the first instance. I think, as I said, the biggest issue really is this expectation management, so that if we change our language so that we don't just talk about, a few cells outside the uterus being the problem, then that really opens up the lines of other alternative management strategies that you can utilize. And if you start talking about these alternative issues, this inflammatory component, which I really think is a big deal, and the usefulness of, say, physiotherapists, um, then I think that's a great thing to do. But I suspect all of you are sort of doing your best at this anyway.
Yeah, we've all felt a bit, as I mentioned before, we've all felt a bit under siege after a lot of the newspaper
Oh,
articles
yeah, I get that.
telling us how we're very bad doctors missing this thing. It's very hard.
But it's hard. It's not easy to do this. So I wouldn't feel as though you're under siege. I mean, like I get it, but um, I think it's unfair what's happening.
Yeah, I think they don't always have a medical input when they write a lot of articles too. But
Exactly. Yeah.
yeah, I think the hard ones, as you mentioned, as someone has mentioned in the chat too, the 16-year-olds where you don't do a laparoscopy, they're the ones
Uh,
that were difficult.
and there's as you were aware that as you would all be well aware, there's a whole pile of secondary issues happening in someone who's 16. Family dynamics, potential issues at school, stress. That's very difficult.
Right. And if we're putting those girls on the combined oral contraceptive pill, should we be putting them on it continuously or particular types of OCPs?
Theoretically, you should be able to go on it continuously, but from a practical perspective, what happens is almost everybody starts getting irregular, weird sort of bleeding. So I sort of start them sort of cycling initially, and then after a few months, suggest that they, take 3 months, sort of, 2 or 3 months continuous, have a withdrawal bleed, and then go back onto that sort of cycle.
And any particular brand that's more useful, sort of like
Oh,
microcolon 30s or rather than 50s,
yeah, I just use Levelins or whatever in the first instance. Microgyna 30, yep.
the more progestogenic ones?
Yes.
Yeah. And the mini pill before Slender sort of came and took over, the traditional mini pill, is that as effective? Is Slender better, or that sort of to
Well,
be lower down in the progesterone list?
back in the day, we used to use a lot of Provera.
Mm.
We still use a reasonable amount of that. So those agents sort of work, but they're perhaps not as efficient.
The Depo-Provera or the
Yep. Well, either Depot or just straight Provera.
yeah,
5
Depo-Provera
milligram
had a lot of
tablets.
publicity. It was a little bit difficult with patients because they read that, causing meningiomas and
Meningiomas,
bone
yeah,
loss.
yeah, 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 yeah.
Now, has anyone got any further questions? We've covered a lot of areas. Please write those in the chat. But it's a very difficult area because I think we don't at this stage have any sort of specific tests to diagnose it sort of thing. Like it'd be nice if we had something where we could use endometrial tissue or something that
Yeah, well, that's
diagnostic.
we thought years ago that you could do a pap smear and then do an endometrial sample and
Mm,
then you'd get a diagnosis, but it just never worked out that way. But look, I think you're all doing a fabulous job, to be honest. I wouldn't be beating yourself up, but look, it's a difficult area.
I think that's right. Patients don't realise it's very difficult when you can't do
Mm,
blood tests and
abs-
see something. Yeah,
absolutely.
yeah. That's fantastic. And if there's no more questions, I might hand over to Lydia. That's been a very comprehensive and very interesting and very informative talk. Thank you, Professor Cooper. That's
Great pleasure.